Hi, everyone. Thank you for joining us this evening. This is Ocean Pediatrics, and this is our first webinar. We're very excited to discuss a very important topic lately, and my name is Jennifer Macchio. I'm actually one of the nurse practitioners for Ocean Pediatrics, and I'm typically in the Laguna Hills office. So looks like we have about 21 attendees right now. So we'll just wait a few moments, probably till around 6:03 or 6:04 to see if more attendees arrive. For the meantime, people who are actually joining us, thank you for being here again. And if you would like, if you look at the Q&A, you can definitely pop in some questions there. We do have a list of questions, of course, that we will go over that you guys have submitted for us. But for the meantime, you can definitely pop in the Q&A, let us know where you're from. That would be greatly appreciated, so we can see if we have everyone from Orange County or LA or wherever you're from. And then, yeah, looks like we're at 23. So we'll just give you guys a couple of minutes and we'll definitely try to get to all of your questions. If you do see the little Q&A question mark that's blue at the bottom, that's where you will enter your questions. So thanks for being here.
This is so exciting.
I know, it's great. Yeah, I actually shared with some friends. Oh, Costa Mesa. Oh, just so you know, if you do, of course, type in the Q&A, no one else can see your response. We can see your responses, but no one else can. So, and we'll kind of keep this private. We don't have to say any names, but thank you. Yay. So we have LA, Costa Mesa. All right.
Familiar names.
See, this is great.
So we go back a long, long, long way. Yeah.
Decades. Oh, that's so sweet. Yeah, thanks. Oh, you're welcome. Thank you.
Thank you for joining.
Yeah.
We even have outside of the county.
Yeah.
No.
Okay, I think we'll give just a few more minutes, and then because we probably have about half of what we're expecting right now. So I think maybe a couple more minutes and we'll get started.
Sounds good.
Yeah, this is great. I know sometimes, of course, it is 6 o'clock our time, so sometimes people are putting kids in bed or dinner.
Exactly. I'm sure people will trickle in. It gets busy at nighttime.
For sure. Lake Forest. Woo! I'm like, that's where I live. Hi.
Maybe neighbors.
Maybe neighbors. All right, well, I guess we can get started. I feel like this is probably going to run for a while. Of course, we're planning on closing the webinar out around 6:45. But again, for you guys probably who just came in, if you do want to submit any more questions, please feel free to do that by clicking the blue question mark at the bottom. Again, no one can see what you're typing except Dr. Belowitz, Dr. Dillon, and myself. So please feel free to do that. And I guess I will start with introducing Dr. Belowitz. So Dr. Stephen Belowitz.
Thank you, Jen, for the introduction. And thank you all for joining tonight. As Jen mentioned, a lot of you are very busy and putting kids down and multitasking. So we appreciate you joining us on such a important and current topic. A little background on myself for those who don't know. I'm the founder of Ocean Pediatrics. I've been practicing in Orange County for a long time. I know it's going to make it sound like I've been around a long, long time and don't want to give away my age, but it's almost 30 years now, and different areas of Orange County. And we've had the pleasure of treating patients, seeing them grow up. And now we have even the bigger pleasure of treating the kids of the kids. So we almost feel like grandparents. But it's been really a pleasure and honor for us. As a practice, myself and my partners, and I introduced Dr. Dillon and none of our partners, we all practice the same medicine. We practice evidence-based medicine. And as I mentioned, we're proud and honored to be serving the families of Orange County. A couple of things that's unique about us in our practice is we're a clinician-owned practice. We, the clinicians, we own the practice. We determine what's best for our patients. We determine how to run the practice. We're not run by corporate entities, private equity, hospital systems, and health systems. Data showing and supporting that has better results and better outcomes. We strongly feel about that. It enables us also to give patients the feel of a family kind of feel, a belonging kind of feel, not working for this kind of big conglomerate or corporation. So we think that's beneficial as well. We emphasize working in collaboration with our families, with our parents and the children. And we emphasize shared medical decision-making. There are, a lot of the things we do is we share and we collaborate and work together. There's some times where parents respect and understand things are super emergent, there's critical situations. We need to sometimes what we call triage and do things urgently, but we practice shared medical decision-making. And as I mentioned, working with our parents, enabling the best care and outcomes for our patients. For us, it's of utmost importance. That's why we created this evening and put together this evening, helping parents understand vaccines and the policy changes, having empathy for the parents. I honestly deeply feel a lot of empathy for parents, especially new parents having children today, with so much information out there, so much confusing information out there, so much misinformation. When we were having kids a couple of decades ago, it was easier. The policies were aligned, they weren't polarized, politics wasn't much into it, so it was much easier to make decisions. We want to partner with our parents to be a source of credibility and trust with our parents, so we can help our parents make the right decision for all medical care, but specifically on the island tonight is the best path to proceed with vaccinations for your child or children. Now I want to pass it on to my pediatrician partner, colleague, and friend, Dr. Dillon Ohal.
Hi, guys. I'm Dillon Ohal, born and raised in Laguna. Very excited to be practicing back here, serving my community with Dr. Abelowitz and serving all of you guys. We're really here tonight because we've had a lot of parents express a lot of confusion, anxiety, concern because, recommendations that have been in place for quite a while got a major overhaul. And not only that, but different organizations are suggesting different things, which at the end of the day, when you're getting conflicting information like that, really puts the impetus back on the parent, which is not only stressful with the amount of information and misinformation out there, like Dr. Bella was mentioning, but it's not fair to parents, So that's why our goal is to partner with you always with all medical decision making and help guide you with evidence-based care. But sometimes our time in the office, as much as I love to sit and kibitz, we don't have enough time, and we wanted to dedicate some time this evening to really dive into these new recommendations, answer questions that you have, and hopefully alleviate some of a lot of your anxieties, and really felt that it was a priority to dedicate extra time to this. So really appreciate you guys joining us. Hopefully we all learn a little something. And like Jen mentioned, if you have any additional questions, feel free to put them in the question and answer section.
Before Jen, just I want to add is that we're, as I mentioned, collaborate, work with our parents. We're coming in as the pediatricians. Of course, you all know we have intensive training, 12, 13, 14, 15 years of training. We have the experience, and we're in the trenches. We're practicing pediatricians. So we we see live right now the effects of when we do vaccinate, when we don't. So I strongly believe we have a lot of credibility with that. A lot of the policy changes are made at times, especially now by entities of those folks who, many of them are not physicians. Almost all of them currently with those policy changes are not hands-on seeing patients. So we see it live, we see a lot of patients, we're very active. So I think that gives us an extra add of credibility as to what we're recommending as well and working with our parents.
Awesome. Thank you. Thank you both for being here and taking time out of your schedule to Dr. Abelowitz and Dr. Dillon to present to parents. So I guess we'll get started with some questions. It looks like we have about 33 in attendance, and I'm sure some more people will trickle in, but we'll start with Dr. Dillon. If you could please probably just briefly discuss the newborn vaccine schedule. I'm guessing this question, it was kind of broad, but probably most of the vaccines are given before 12 months. So
so I can kind of do a quick overview of the updates and then how it maybe might change or how it would affect the newborn vaccination schedule. So the CDC recently came out with a new sort of 3-category framework. So instead of vaccines that initially were recommended universally to all children, they stratified them into recommended for children, all children, recommended for children only in high-risk groups, and then recommended through shared clinical decision-making. Overall, that reduces the number of routine recommended vaccinations per the CDC. Though largely the vaccines, even with this updated recommendation, vaccines for infants remain largely the same. The biggest difference is for shared clinical decision-making. I would say now the flu and COVID vaccine are under that shared clinical decision-making umbrella, as well as flu, hepatitis B, hepatitis A, and meningococcal disease or certain meningococcal disease immunization. In general, for kids, for babies under 1, we like to have at least 3 doses of DTaP to protect against pertussis, 3 doses of a pneumococcal vaccination to protect against strep pneumomeningitis, 3 doses of Hib, which is Haemophilus influenza B, which also protects against infants from getting meningitis. These are bacteria that are were relatively ubiquitous. They can cause ear infections, pneumonias, and such, but in younger children and infants, because their immune system isn't as strong and because their blood-brain barrier isn't as effective as older children and adults, these bacteria, instead of causing mild or moderate localized infections, can cause meningitis or encephalitis infections in the brain. So we like to get those in. And then hepatitis B. Hepatitis B is typically given 3 doses in infancy. With the new recommendations from the CDC, that's not necessarily universally recommended at birth from the CDC, but we have to keep the broader picture in mind, which so the first point that I sort of wanted to make was that in the past couple of days, the AAP has released their recommendation for the childhood immunization schedule. This is the first time, certainly in my career, that the AAP has differed from the CDC, which I think causes a lot of uncertainty and anxiety with parents, which makes a lot of sense. So a couple points I want to make about that. One is the AAP recommendations. There haven't essentially been any changes from prior recommendations because there hasn't been any new evidence that demonstrates any change in our knowledge of the safety and efficacy of these vaccines. And the 12 plus other American Medical Association groups, so ACOG, which is obstetricians and gynecologists, the Infectious Disease Society of America, the IDSA, all of those societies are aligned with the AAP. So even though we're getting some conflicting information, just for clarity's sake, the CDC and the associated ACIP are sort of the aberration from the rest of our governing bodies that are maybe less involved on the political side and more on the research and medical care side. But the reason we give a lot of shots to little ones is not because little ones are technically more exposed to those bacteria or viruses, but in general, it's because they're more vulnerable if they are exposed. And so those recommendations alter slightly what infants would get, but not it does not alter what we think your infant should get, because we're still aligned with the AAP and the majority of the other American medical groups that have kind of chimed in.
If I could add as well, thanks, Dr. Dillon, and then we're going to...
I've rambled on there a bit.
No, you did amazing, and we're going to do the same thing with me, please. When I do, we love to tag team on that. So and from our different perspectives, of course, we 100% agree. It's unfortunate that we're in our polarized political times, that politics has penetrated in every ways of our life, and especially here into medicine, that is so critical, because decision makings and all on what parents are going to do with their children, they're potentially life-threatening and life-changing. So it's really unfortunate for me, practicing, as I mentioned, 30 years up until pre-COVID. There were always some issues and debates and all, but it wasn't very, very politicized. And it's so politicized today from that perspective, which is really has me concerned seeing that and witnessing that. And I wanted to just mention that, going back, I believe this really became more polarized back in COVID time, and 5 years ago, with some recommendations and decision makings were made that what I believe instilled a lot of mistrust to a lot of the community, and that what I call vaccine hesitancy really became rampant. So there again, that's our empathy, understanding that, and especially now over the last year, for obvious reasons, you all know now that it's been politicized on the other spectrum into healthcare, and a big part of the healthcare decision making in all the CDC is controlled by more, let's say, politicians versus true healthcare advocates and people, as I mentioned, that practice medicine, that are in there in the trenches with kids, see it every day. So it's unfortunate you guys are stuck in the. I always tell my patients, you're all stuck in the middle. We're stuck with you in the middle. We're there to help you figure it out together. But it's a rough spot for you guys to be in it. And it's not about us here, but it's a rough spot for us because we feel for you. And I always tell parents, you're ultimately going to make the decision. It's rougher and harder for you. Specifically on the newborn period, I just want to touch because it's a confusing period when giving birth at the hospital. Parents have now this kind of a la carte decision-making to make per social media, politics, and all of that. And there's really 4 items there when you're having a baby that are going to be addressed. Hepatitis B, which Dr. Dillon mentioned, and I think there's probably questions about that. The erythromycin ointment, which unfortunately, we're seeing more parents refuse that. And the RSV vaccine, and the most frightening for Mary is the vitamin K. Yes, it's not a vaccine. By the way, RSV is not a vaccine, it's an antibody. We all think, and I even just said that 30 seconds ago. And vitamin K, which is frightening for us. I'm petrified waiting to see that first case of a significant internal bleeding or brain bleeding and all of that, because some of those folks that are not doing vitamin K. So tough situation, a lot of choices. I know there are a bunch of questions, so I don't want to go over each of those items. Bottom line is we do recommend them all. We do discuss all of them with our parents and work with the way for them to understand and work through with it.
Perfect. Thank you. So the second question basically says, can I still keep my child on the AAP schedule, the original schedule? Yes. I think.
Yeah, that's the short answer is yes.
Yeah.
Easy one.
Yeah, exactly. And insurance, as of now, insurance is covering it. California schools are still consistent with prior requirements for public schooling in all the regions. Those requirements haven't changed. And insurance has continued to promise to cover all the AAP recommended immunizations and that schedule.
And I think the fact, and I agree, and that's in California. We know that different states may veer towards doing other guidelines, but I believe California will stay with the AAP's guidelines and the 20 major medical and health organizations guidelines, because that's regarded as the credible resource. Unfortunately, today, the CDC has lost some of its credibility. And as I mentioned, even a few years ago, before it was so aligned, it was so together, and that has changed. The fact that insurance companies are continuing to vow to continue cover it goes to show the effectiveness of the vaccine. I'm not here to kind of downplay vaccine insurance companies, but we all know insurance companies are there for profit, and they're there to make money. And bottom line, the fact that they believe that vaccines prevents serious consequences, what they're worried about is major hospitalizations and what we call high morbidity. And that's cost them tens, hundreds of thousands, sometimes millions of dollars. The facts they're standing by covering for vaccines, which are costly items, I think even it gives more credibility to the importance of vaccines and the effectiveness of vaccines.
Yeah, great point. That's great. I thought this was an interesting question because I know parents a lot of times are very hesitant about how many vaccines they should get at one visit. So that's one of the questions is how many are too many, right? If a kid is due for 6 shots, is that too many? Do you guys cut off at a certain number if the parents are totally okay doing 6 shots at one time? Dr. Sor.
Yeah, I can. The short answer is no. If the schedule, the immunization schedule that the AAP recommends, they look very closely at age ranges and when we can give those vaccines and layer them and the safety of that. So there are scenarios where a child may be due for 6 vaccinations, and that's perfectly safe to do. Grouping them like that will reduce future pokes. There's no real good evidence that shows us there's higher risk of side effects for doing multiple vaccines versus one vaccine in a visit. That being said, we have lots of families that prefer to space them out, do them individually. And so we always work with families on that every day. We've got families that prefer to space them out. There's actually, I believe, a question on here about risks and benefits of spacing them out. The main risk is that you're delaying that layer of protection. But the benefit is that your comfort level with what we are suggesting with your child is really, really important. And if you're concerned they're going to be too sore or too fussy with too many shots, then we'll always work with you to create a customized schedule. We're happy to do that. But in general, if it's recommended, it's safe. They might be mad at us when we're in the office or mad at my MA because I make her do it instead of me. But it is considered safe, but we'll always work with you with something that you're comfortable with.
And I agree, just going back to schedules and seeing babies and seeing kids from all ages, I don't recall many instances of actually 6 shots. I think the most currently I can think of because of the combination vaccines is actually 3 shots and the drop by mouth. That has more vaccines in it. And I know there are concerns about the combinations and all. Yeah, 6 shots just off the cuff without being a doctor, not taking the doctor hat off. Sounds a lot, sounds painful. And it's quite the unusual scenario. Interestingly enough, a lot of those folks that get into that situation is when they're very delayed on the vaccines and they have to get kids registered for school. That may be a scenario where parents are like, just get this over with, get it all with. But yeah, 6 shots from a scientific safety data standpoint, we don't have concerns with that. It's more that, like Dr. Dillon mentioned, 6 shots sounds painful to me. I've never got 6 once. I think more than 2 or 3 or 4 back in the day. But but from a safety standpoint, and I think it's important to emphasize the safety of vaccines. It's only the actually recommended schedule by the American Academy of Pediatrics up until recently was the CDC. That's the safe schedule. Any other alternative schedule, which we work with parents, we understand them, we balance the fear and the anxiety with that. Any other vaccine schedule, that safety and even effectiveness hasn't really been proven. So there are folks on the other side of the spectrum there, and I respect those physicians and pediatricians who say, hey, you don't do it by the schedule, it's not a good fit for our practice, because they're worried about the effectiveness and the safety of that. So tough decisions for pediatricians to make. There's not everyone's exactly 100% on the same page. And in every profession, you have your outliers that unfortunately may take advantage of it from one way to the other. But it's really important to emphasize the safety and effectiveness is actually just the schedule that is recommended. Anything outside of that schedule, we are shooting a little bit in the dark.
Great, thank you. I think that's as far as the schedule changes and the recommendations, I think that was covered pretty thoroughly. I think that was really great. So no changes that we're making in the office. We're still following AAP guidelines. The last question would be for the vaccines. How can a child be exempt from the second dose of MMR? Of course, usually they get their first one at 12 months. We do see some parents who get it at 6 months if they're traveling or there, of course, are measles outbreaks. But how do we avoid that booster? Anyway.
So I think a true exemption, and especially in the state of California to date, is if there's a medical contraindication, severe allergies, severe adverse effects prior. Currently, religious exemption and other exemptions are are not accepted in the school systems in California, even to the extent in California that physicians that have given exempts without the appropriate exemptions have actually got themselves into trouble, have had their license taken away, have been suspended for a while. So currently in California, unless I'm missing something, Dr. Dillon, on an exemption standpoint, besides a true medical contraindication, or
Yeah, it has to be a medical contraindication. It previously, if we got positive titers for measles, mumps, and rubella from the first vaccination, some schools would accept that, but now we have to put everything through the CareMe platform, which essentially reviews to make sure that, and reviews our licensure and reviews the medical exemption paperwork. We have to submit that in order to be the exemption to be formalized. So, and that also involves extensive blood work, and it tends to be more invasive and upsetting to patients. So largely we recommend getting that second vaccine because it really does capture that 5 to 10% of children who just don't, for whatever reason, mount the appropriate immune response to the first one, and tends to have much less side effects and distress than the blood testing that may not even get you the exemption that you're looking for.
Definitely seeing that too. That's what I was going to say. If they don't have antibodies, then they get a blood draw and then they have to get the
shot. Yeah.
Yeah. So that's not fun either. Another question is when and where will data be shared on populations getting vaccinated versus not being vaccinated? Anyone have any questions?
Do you want to go for that one, or should I? That's a harder question.
Yeah.
It's not 100. We know, we are aware of things. We all know, but that's I'm going to say less clinical. But I don't know if you're comfortable, Dr. Dillon, or
it may take a long time to accrue that kind of data because vaccine hesitancy, as it grows, we may see larger portions of the population unvaccinated. But keep in mind, this is communicable disease, and vaccines are very effective, but sometimes not 100%. So that it does become a little convoluted. That being said, the concrete information that we do have is reduction in rates since those vaccines have been initiated. So for example, since hepatitis B vaccine was started to be recommended at birth, we've seen a 90% reduction or 95% reduction in infant hepatitis B infection, which the vast majority of time goes on to chronic infection, as well as like cirrhosis and liver cancer and stuff that we really want to avoid. HPV vaccination, since that's been instituted, early data is showing that we're going to save hundreds of thousands of women's lives from cervical cancer. So we have a lot of good data that shows how effective and vaccines are preventing mortality and morbidity once they've been instituted. As vaccine, unfortunately, if we see less and less vaccination, it may take us a while to accrue data to show how that negatively impacts our population's health, though you do see pockets of that. I mean, the measles outbreak happening in South Carolina right now, the one in Texas, we are starting to see measles as sort of our test case for vaccine hesitancy and the tragic outcomes we can see from that. And so it may take a while, but we do have some really good data supporting how much disease burden vaccine reduces.
And I think there, also to emphasize, there are multiple entities and organizations that are following and undergoing surveillance of the data, including the CDC, the WHO, peer-to-peer references, scientific, organizations and journals, the American Academy of Pediatrics. Vaccines are given a lot of attention, constantly monitored. It's a moving target, as Dr. Dillon mentioned, especially now as we're seeing a higher percentage of the population not receiving the vaccines. So unfortunately, we're seeing outbreaks, as Dillon mentioned, in South Carolina, in Texas, of measles specifically. And there's a rise in pertussis. I believe last year may have been close to 30,000 cases of pertussis whooping cough. So multiple entities, CDC, WHO, peer reviews, and many more that are surveilling and collecting data and reporting data. The trick really is who gets it, who reviews it, who makes the decisions based on, because you can always find outlying study here and outlying study there. Fortunately, that's what the CDC tends to be doing, is kind of grabbing onto, some unrelated to us in the US, but it's Denmark study and changing the schedule based on that. So it is a complex, kind of a little out of our pure wheelhouse of how that's all put together and retrieved. we rely and trust on our, as I mentioned, education, being in the trenches, following the data, following the news as you all do as well, putting that all together and coming to a decision together with parents on what's best for your child.
One thing that I'll just mention briefly is I was a floor nurse for many years, and I will say I worked as a floor nurse like early 2000s in a hospital that just had a pediatric floor, not a children's hospital. And it was prior to the rotavirus vaccine coming out. And I can't tell you, and this is what I usually tell my patients who are hesitant, is I can't tell you the number of patients I would see, toddlers, babies, just severely dehydrated who were admitted for IV fluids. Anyway, fast forward, vaccine comes out. Then I moved to Florida, work in a children's hospital, and we were not admitting any rotavirus babies. So just the change in that, and I think there's actually a podcast about it, but actually to be part of that was really, I guess now I realize it more with people, of course, parents being hesitant. I think back to those times, and then, things got better. So anyway.
And I think it's great to put anecdotal and real life experience, as you mentioned, specifically with Rota. From my perspective, my experience, we're starting to see a rise in the country. Just recently had a mom who delivered a baby. She got Rota, and I haven't seen Rota now for I don't know how long, maybe a couple of decades. She landed up in the intensive care unit. I haven't seen any babies or kids getting it yet. I have seen in my career back before rotavirus, kids with dehydration, and I don't want to frighten you all now, a lot worse than that. One child didn't make it from rotavirus. So I've seen that and been involved with that during my training with my own eyes and hands. And we're seeing a resurgence. All these are going to start coming back. Part of it is getting us backwards decades because of all these policy changes. Another anecdote I like to mention just recently, because being in the trenches and seeing this all happening live, RSV. RSV, the antibody, we didn't have this until couple of years ago, 2 or 3 years ago. Used to be one of the more frightening things we'd see on babies, especially very young babies, especially under 2 months, under 6 weeks, especially under a month, especially those kids that have older siblings. So anecdotally in our practice, and this is just from patients I've taken care of, I'm sure some of my colleagues, just recently had a 4-month-old that was hospitalized, unfortunately didn't receive the vaccine, needed oxygen, was really sick. Fortunately, came in early, treated and did well. Just today, I saw a follow-up on a 3-week-old, got the antibody, sibling had RSV, so they got it. So the child got RSV, but a mild cold with it been following the last few days, and looks unbelievable. And based on my experience and seeing, the odds are this child would have been hospitalized. So in front of us just today, seeing what vaccines or antibodies do, and where we're going to go backwards, not doing the things we're doing, does upset me and does scare me.
Yeah, the Beyfortus, which is the RSV antibody, that one really stings because we hate RSV. We hate it. There's so little we can do, especially when the little ones get RSV, especially in the office setting. It's largely sending you to the emergency room to be hospitalized for invasive supportive care. And we don't like not being able to help you. And there's very little we can do to help in the outpatient setting. And Beyfortus was one of the ones that was switched from this for the CDC back from universally recommended, and we just got it. We just got it for all babies. And it was so exciting. We finally had a tool to fight it, and rolled back to only high risk, which is what we had for decades. We've had the Beyfortus technology for decades. It was called Synagis. It was tens of thousands of dollars, and it was only for really high risk babies with cardiac and respiratory issues. And now we finally got this layer of, basically I considered it like a blanket over all of our babies to protect them from RSV. And they're trying to unswaddle my babies. And so that one stings a little bit, but we are still carrying that in the office and strongly recommend it for the stories that Dr. Abelowitz has told you here.
Yeah, thank you. Next question, I would say, because I feel like a lot of y'all are answering a lot of questions, so I'm trying to kind of filter through here.
That's fine. Yeah, we are.
Yeah. So, so the purpose of the hepatitis B vaccine at birth, I feel like you covered that pretty well. What do you think? I know we definitely talked about it.
Hepatitis B at birth classically is in case of perinatal transmission. So from mother to baby, if you give it within the first 24 hours, reduces the risk by 90%. We do screen moms now for hepatitis B, generally, if they have good prenatal care. We found about half of cases of newborn RSV, RSV. See, my brain's obsessed with it. Newborn Hep B, they can be transmitted not just from mom or in the newborn period, but up to half are transmitted from other adults that may not have been screened. We don't have universal screening here for hepatitis B the way that they do in other countries. So that's why it's recommended at birth, is to reduce that risk. And again, because babies, if they get Hep B, if adults get it, sometimes they can clear the infection. Babies almost universally do not. They end up getting chronic hepatitis B, liver scarring, and a significant risk for liver cancer.
And just to add on from the perspective of hepatitis B, going back, and again, I always put my 30 years in there, but going back the first 20 years of practices, I would strongly recommend hepatitis B in the newborn period when seeing the folks. And then the hepatitis B hesitancy started somewhat. And then for those moms who were hepatitis B negative and those parents worried, we were like, okay, you can do it later in the office. We'll figure it out when we do it. Now, actually, because of the vaccine hesitancy and the growth in the amount of folks not getting vaccinated and the worry about, as I mentioned, a lot of these things coming back, I'm actually pushing it more. But of course, those folks who want to do that later in the office or discuss it with us, as I mentioned, we discuss that with parents and we leave that ultimate decision up to them in the newborn period.
Thank you. This is kind of same question, I think, in a way. If you can just discuss the vaccines that are no longer recommended by the CDC as far as medical decision making, of course, being HPV, meningitis, Hep A, Hep B.
So I think Dr. Dillon mentioned, I think you touched on it on your opening on the ones is, and we'll complement each other I have it in front of me too, just because it's a list and it's a new list.
Okay.
So I'll start with hepatitis A, hepatitis B, rotavirus, certain meningococcal viruses, and COVID could be put into the mix or not. I don't think I understand what the CDC, and I always tell parents, it's not that they're not recommending it, but they're shifting it to those at risk and those that need to have shared medical decision making. So they're turfing those 7 to the parents and to the physicians. That's kind of my perception. I'm not sure, Dr. Dillon, if you're looking at it from a different perspective.
Yeah, they're essentially turfing that decision making onto parents, which isn't particularly fair. And also keep in mind, classically, the concept of shared clinical decision making, it was working with families to decide between 2 equally acceptable options. So for example, if your child has an ear infection and they're a little bit older, we can decide to treat with an antibiotic, or we can watch and wait for a couple of days. They have done research that shows they have equal acceptable outcomes. Vaccinating your child against meningitis versus not vaccinating your child against meningitis, to me, don't have acceptable equal risk profiles. So it's sort of a commandeering of that term so that parents feel that they, because we want parents to be informed and be empowered and make decisions for their children. But that term classically has been sort of, the definition has been shifted. And so keeping in mind that these protecting your child with these vaccines that have been demonstrated to be safe and effective for decades now, is what we would with the evidence-based recommendation. So shared clinical decision making in the sense that we want to collaborate with you and inform you and advise you 100%. But I'm not coming at you saying vaccinating your child against meningitis and not vaccinating your child are equally good options. To me, the good option is protecting your child against bacterial infections in the brain. So that's, I think, where a lot of the confusion for that term comes in, these recategorizing. It's because it's sort of a misuse of that term. And it puts a lot of pressure and unfair stress onto parents.
Thank you. I think these are some good questions. I mean, they're all great questions. But specifically, of course, we get lots of questions about safety and ingredients. So this is, what ingredients are in vaccines and how will they affect our children? Dr. Abelowitz. I'll give Dr. Dillon a little break. She just
Sorry, I am chatty Cathy.
So from the components of the vaccines. So of course, we know there are a lot of components. And first of all, the first and foremost are the antigens that are in the vaccines. Of course, that's the effective component, and that's what we need to help with the immune system creating its effect of building up protection against this specific infection. So the actual antigens, and we went through the list of all the different vaccines and antigens. And then we go into what we call the boosters. What helps boost the antigen effect? And that gets a lot of discussions is aluminum. And so there are, in some of the vaccines, amount of aluminum. So the aluminum in there is to boost the effect of the vaccine so you don't have to put so many antigens in there. And the discussion of aluminum is, okay, that high aluminum can have an effect on the child. When looking at the data, these are real, almost negligible amounts of, or real small amounts of aluminum. The amount of aluminum when measured and when samples have been taken from children and babies, and studies have been done, the amount of aluminum in babies after all the vaccines together, with a multiple, the amount of aluminum in breastfed babies, and we're big breastfeeding proponents and encouraging, but the amount of aluminum in breast milk is much higher than all the vaccines put together. So that emphasizes, and of course there's different studies as we mentioned, emphasizes from our perspective that aluminum, the amount of aluminum, the small amount of aluminum are if not negligible, but not enough to cause us a concern. And then, of course, preservatives. Actually, many of the vaccines don't have true preservatives in them anymore. And again, most of the amount of trace preservatives that may be left over actually from the machinery that produces them may have some trace there, so negligible that, and again, from what we're exposed to in the environment, many of those components we're more exposed to in the environment in our blood is more of that component than what are in the vaccines. Then they call what they call the stabilizers. So there's a couple of components, sugar components and some protein components that are safe and that help stabilize from heat and temperature. So I think that covers most of the components of the vaccine. Dr. Dillon, not sure if you have anything to add from the components of the vaccine.
No, that pretty much covers it. I mean, there's some elements how the vaccines are produced. Sometimes if they're produced in, like for the example, certain flu vaccines produced in chicken egg. So there's sometimes concern about cross-reaction or allergy. In general, the risk of allergy, even in egg allergic children, is so low that those flu vaccines are still recommended. Though at our office, we carry Flucelvax, which is not generated using chick eggs, I don't believe. So that risk is removed. That's pretty much it. I think you covered all of it.
Yeah, great. Thank you. And I think this is, again, I think they're all great questions, but myself, of course, having a 6-year-old daughter, I do find myself in the community, some parents who are not vaccinating their kids. And this question, of course, is, should we allow our kids to spend time with unvaccinated kids? Dr. Dillon.
It's a tough question. I mean, it's always a choice of your personal tolerance of risk. Depends on a lot of factors. Of course, if your child is an infant, particularly an infant under the age of 1 who's going to be hanging out with unvaccinated children, if they're immunocompromised or anyone in your family is immunocompromised, or other high-risk individuals in your household. What you can only control what you can control too. You don't always know if your child walks up to another child at the park what their vaccination schedule is. So I like to tell my families to focus on what they can control. So making sure your child is fully vaccinated on the schedule, if that's your preference, it's certainly mine. Making sure you're using reasonable hand hygiene, hand washing, starting that from a young age. Keeping your child, or particularly your infant, away from sick people, particularly kids. I like to joke that from October to May, just assume everyone under 15 is sick. So if you have a little one at home, really little one, kids need to stay a few feet away or play with the baby's feet so you can mitigate your own risk. But we do live in a world. That's kind of the nature of living in a society, living in a community, and communicable disease. There's always going to be some risk. And that's sort of the nature of vaccination too. You're not just protecting your own child when you vaccinate, you're protecting the community. It's kind of the nature of epidemiology and communicable disease. So it can be hard sometimes for parents to wrap their head around, my child has a low risk for such and such illness, and they may be 100% correct. But the more people that say that, the more circulating illness we have, and then everyone's child is at higher risk. So if you just do what you can to protect your own child, and then I always say, if you're worried about a family member or a friend who doesn't vaccinate, you're worried about spending time with them, but it's socially uncomfortable, you can always blame me. I'm happy to take that blame. Dr. Dillon says that we need to keep the baby away from any toddlers that are sick or any toddlers that are unvaccinated. I'll jump on that grenade every time.
I use the same lines, so I totally say is blame me. I think with me, I'm a little more particular and specific on the very young. I think it's, of course, if they're high risk and they're immunocompromised. So the young is where I find a lot of the parents need guidance or looking for guidance from me. So I like to categorize. There's no scientific data supporting what I'm going to tell you all now, because they're at least from what I know. So I like to look at the first month as a very vulnerable period of exposure. So I'm quite particular about being really cautious around other people, especially unvaccinated children, not only from the perspective of protecting them from illnesses. If a baby under a month, I don't know if you're all aware, has a fever and we're not sure where the fever is coming in, that's almost an automatic hospitalization. That's a lumbar puncture, that's a catheter, a bunch of blood work, a hospitalization for a few days, maybe even antibiotics. So there's also that perspective. I like to always bring in real life. A few days ago, or maybe it was a week ago, had a patient that they were catching up on vaccines. So we put them in the category of undervaccinated. The child had a febrile seizure, unrelated to the vaccine. When they went to the hospital, because the child was unvaccinated, they had to run and do a lot more tests than they would have had to do otherwise, because they weren't sure if the child. So you put your child at risk for a bunch of other things as well when you're not vaccinated. So back to that, I'm really particular about the first month of exposure. Of course, parents will choose who they want to be in around, but I give them guidance on that. And then I go from a 1 to 3 months where I'd say I'm semi-particular. And then after 3 or 4 months, and they've had a few sets of vaccines, and the kids are well and they're thriving, I kind of open the doors. And then totally with regard to unvaccinated children have got a lot of the vaccines, and we're not dealing with the current pandemic or epidemic. I'm more open to them being around from a personal standpoint of folks that are unvaccinated.
That's perfect. Thank you. As far as the schools, do you guys know if any of the schools are adopting the CDC changes, or are they sticking with the AAP?
Not in California. As of yet, I doubt that's going to happen in California. I can't speak for other states. I think there's some rumblings of certain states. One particular comes to mind, maybe even two. I'm sure you're thinking the same, that there's been some discussions about that. But from a school standpoint in California, I currently no change at all. Schools, as well as insurance companies, and all, as I mentioned, the 12 credible health organizations in our country, including the AAP and the list Dr. Dillon mentioned, are sticking by the regular schedule and not going to be changing that. I doubt California is going to change.
I don't think so.
Okay. I think we've covered a majority of the questions. Honestly, I think most of them. I do see another question that popped up on the Q&A, which says vaccines take a lot of the blame for causing neurological development issues, allergies, autoimmune, eczema, etc. Given there's no scientific data to support a direct link between vaccines and these problems, what do you think is causing the rise in them? And then what can parents do to try to prevent?
I think it's a combination of factors. Like you mentioned, there's been no data to support any neurologic developmental issues being caused by vaccination, but we are getting a heck of a lot better at diagnosing neurologic and developmental disabilities as we have for the past couple decades, as well as broadening diagnostic criteria so that children that maybe have less severe symptoms are still getting the support and the therapies that they need. And then in terms of autoimmune and eczema, there's a portion of that that's particularly autoimmune that's just better diagnostics. But there's a hygiene hypothesis as well that we're exposing children to, as we protect them more and more and expose them to less viruses and bacteria when they're very little to prevent bad outcomes. There's a possibility that their immune system isn't getting primed the way that it used to be, and potentially could increase the risk of those types of things. But autoimmune disease is actually what they're often triggered by are viral or bacterial infections. So, for example, type 1 diabetes is typically preceded by viral infection, something that really triggers your immune system. The more sick you get, the more your immune system turns on, and then it can start to target the wrong things, as opposed to a vaccination, which has a much, much lower, what we call antigenicity, or amount of stimulation of your immune system. So it's much less likely for it to stimulate your immune system and cause something like that. In terms of trying to prevent, eczema is largely genetic, and it's largely, it's very challenging to prevent, but there's very effective ways to treat it. Sometimes it can be pretty stubborn, but that's something we can always discuss in our office one-on-one if your child is having eczema or eczema-like symptoms, as well as autoimmune disease and preventing those.
Yeah, I'd like to add on, I agree 100% with what Dr. Dillon mentioned. And there even, often they throw out this terminology in the current political environment. There's, vaccines need to be studied more, they need to be looked at more. I don't know of anything that has been studied so much, has been discussed so much than any other subject in medicine that in my years of experience. And even when really digging into some, we could spend years just digging into that. And of course, we have to take care of patients and we can. There are a number of studies, ironically, showing sometimes the opposite. When they've done, and that's actually came from Europe, studies on hundreds of thousands of kids, and they compared it some, actually Denmark of all places, I believe was one of them in Scandinavia, took hundreds of thousands of kids who got vaccines, hundreds of thousands who didn't get vaccines. Ironically, those kids who didn't get vaccines had a higher prevalence of autism and some other neurological entities. That doesn't mean doing or don't really. I don't think there's really a correlation between the two. And either way, I don't think vaccines protect you. Don't get me wrong, protect you from having, having a child that develops or shows signs of autism. But just want to show how complex it is, how it's looked at, and we're confident that vaccines do not increase the risk for autism and other neurological entities, as well as Dr. Dillon detailed on allergies and eczema and others. Always go back to personal experience and anecdotal, and always go back to how many years, back to the late 1990s and in the early 2000s, when we had a tech boom, and I was new in my practice. The amount of kids that had diagnosed, this was just the actual global amount of autism has increased because of the way we diagnose this and how it's more for importance for early intervention to diagnose it more, and how that the criteria have opened up so much. But the amount of young kids compared to today were actually much higher in my practice with the tech boom. Going back to where we believe there's a genetic correlation, I believe there's more than 100 different mix of causes of what leads to autism and other neurological disorders. I believe strongly that there is no correlation. Now, the outliers, the unique cases, and there is going to be that one of child that had an adverse reaction that could have really, led to a fever or some other outcome. Those are, but the hundreds and the millions of lives that have been saved. The problem with vaccines, we don't know the millions of lives that we've saved. We only know those that got sick. So, but when you look at the data and you look at experience and you look at how many kids I have to hospitalize, this, as I mentioned, this season one, who didn't get the RSV vaccine, 30 years ago in training, a practice like ours would have had hundreds of kids in the winter season hospitalized.
Such a
Thank
good point. You don't see the children that are at home healthy, and where I trained at a different period than Stephen, there was a lot of stuff that I didn't get to see in person. I didn't get to see. I was at CHLA training, and I saw one case of measles. I saw one case of Haemophilus influenza B. And I think of it as a privilege. I had to learn it through books because, God willing, it wasn't going to become an issue again. And that's what we're sort of trying to educate and fighting for now.
Okay, and I am so sorry. I think I may have still had on the my audio when our cleaning crew came in. So I apologize. I realized I don't think I turned off my mic, so apologies for that. I know we're running out of time, and I think this has just been fabulous. Even for myself, it's really great. Of course, I see Dr. Belowitz and Dr. Dillon often, but just actually to speak to them for a solid hour without any interruptions is just, it makes me feel good. So I think one thing to I like this one. Can you separate MMR, or does it have to be a combo? Just real quickly, I think that's a good one for some parents.
I can go for. I think it used to be available. It's not available to the best of my knowledge. Dr. Dillon, I know we haven't done it for many years. I don't believe it's available, easily available at least. I don't think it's available at all anymore.
It's not. It's no longer manufactured because the combination vaccine was found to be more effective. And so at preventing the individual illnesses. And so it was just a superior product. So they stopped manufacturing the individual ones.
Yes. Let's see. These are all great questions, and we will definitely. The plan, of course, is to get to these questions that we were not able to get to. Insurance coverage. Yes, your vaccines. I think we covered that. Your vaccines will still be covered by health insurance. That's not an issue to worry about. So, yeah, I think this is great. We're at 6:57. So
thank you guys all so much for tuning in. We really appreciate you taking time out of your evening to learn a little bit with us.
yes,
And thank you, Jen, for moderating and for directing us and keeping us in line. And thank you, Dr. Dillon, for for doing this together with us. And we encourage and welcome any parents who want to call our office, want to ask us, want to meet with us. We do spend time counseling and discussing vaccines. And we are a growing practice, and we're happy to see you and your children. I know some of you are already patients of ours, and we'd love to see you all.
yes, thank you. And you can see the last slide that shows there's a QR code you can click on. We are available, of course, Monday through Friday. Our Ladera Ranch office is open on Saturday, and then we also have the Laguna Hills office that's now open on Sunday. We're available 24/7, triage. We have that available too 24/7. So yeah, we look forward to seeing you. Reach out to us anytime with any questions or concerns. Thank y'all. That was great.
I want to just
Thank
add from
you guys so much.
As one of us is backing up the triage nurses. So 24/7 us clinicians are on. So if folks want to, the CHOC triage nurses are outstanding and a great service too, but that's after hours when we're not in the office, but we're always backing on. So 24/7, there's always access to us. And as Jen mentioned, I want to emphasize Saturday and Sunday clinics. It takes a lot. It's our, clinicians. Jen's actually one of those who does the Sunday clinic in our Laguna Hills, having your medical home. I never spoke about how important a medical home is. And in a private physician-owned practice, medical home, that you're in the same EMR, you get to see the clinicians that are part of our team. We see babies in the hospitals. We have to follow them up for jaundice and all kinds of things, so that we're open on the weekends, I think is a real add for our patients. We're fortunate that we have the team and staff like Jen and our amazing support team that are willing to be there. We appreciate that. And I think it's safer, better for our patients, and it's a lot more convenient for our families.
Yeah, great. Thank you. And then on our website too, we do have a newsletter you can sign up for. So we highly recommend you signing up for that. And if you'd like us to have another webinar, I think we'd be on board for that too. So I'm sorry, I know we didn't answer some questions, but we were just trying to focus, of course, more on vaccines for this evening, but we would definitely, I think, be happy to schedule another webinar. So send us some more.
Yes, send us some topics. You can follow us on Instagram and DM it if there's
Yeah.
anything you guys want to discuss.
Great. Thank you. Have a great night.
Have a good night, everybody.
Bye. Good night, everyone.